All right, guys, we got another great case from Chris Brown, our shockwave moderator and head of complex interventions at Swedish Heart. Chris, take us through your case, bro.
Hey guys, I got a patient here, real bad angina, interestingly, has a bypass right, looks really good. Has a bypass, you can kind of tell to this like low-lying marginal system, but nothing to this marginal. Has a Lima to LAD that's patent. And so really you can't really see it because this atrial clip thing, but you can sort of imagine that behind here there's some stenosis. There's also a previous stent here that somebody else has ballooned, but never really modified the plaque or the calcium of. And so we took some pictures here. You can kind of see it a little better here, but still behind the clip. And then you can, of course, see the bypassed LAD. And so it's hard to appreciate, but this is a non-compliant balloon. And then this is my shockwave. You can see how constrained this is. I was a little surprised here. I'll show you the IVUS in a minute. I didn't think it was going to be as constrained as it was. But it turns out that it's also mostly nodular calcium. And this is just me working through shocks here. And this is, unlike some of the other cases we talk about where I get 10 pulses in because I have concentric calcium and we modify it. These nodules take a lot of your pulses. And I think that's going to be a big thing as C2 plus comes out, because you're going to get double the pulses. And so you're going to have more of an ability to really modify eccentric plaque, because it can be really hard with eccentric calcium to get any modification of any kind with any tool. But the more shocks you have, the better it is, because you're just not getting all the focused energy onto it. And so we're just going to
Chris, do you try to focus the emitter on the nodule when you're doing these?
I mean, I try and move it 1 millimeter at a time. So because, the balloon, sometimes it'll re-advance through the calcium and sometimes it's a little hard to push around. So I try and put it as far as I can get it, or as far as I want it, with whatever guide extension and support wire I'm going to use. And then I slowly march it back, trying to move it about 1 millimeter at a time, just trying to move those emitters across the nodule of the calcium. Of course, the way the emitter works is it creates a field that is roughly equal across the entire balloon length between the two emitters. But that being said, there's still a little bit of a mountain or a little bit of a peak effect at each emitter. And so I try to move them or march them through with the idea that we're just getting focused energy, or the highest level of focused energy, in little peaks all along the nodule of calcium if I can.
I think it's also important to note, like when you're pulling the shockwave balloon back, it almost always sucks the guide in. So just to be cognizant of that, so you don't dissect the left main, because you're inherently in calcified vessels and you're going to have a lot of friction on the balloon. So I always try to pull my guide back a little bit, or at least be cognizant of where my guide tip is.
I think it's a really good point. And I think, if you use a guide extension, I like to advance the guide extension back to the shockwave each time I want to move it. It acts sort of as like a foot against a fence or whatever you're pulling against, as a little bit of a lever arm. It also kind of frees the balloon up, and you can move it in slightly smaller increments, if you will. And it's these hydrophilic guide extensions are very soft and very unlikely to dissect. So they kind of give you a little bit of protection from all those different things. And since they're so one-to-one adjacent to the guide itself, it's sort of just acting like a dilator. So if the guide does slip in some, it's just going to slide on the guide extension. It's not going to do any, sort of ice cream scooping of anything or really cause any trauma. And so that's sort of something I like to use when I have one in. If I don't, of course, like you say, you got to kind of be real smart and focused on either disengaging it or, keeping it a mindful eye on it. It's much like when you're taking your retrograde gear out of a CTO. You just have to really be aware that there is more tension than you think. And as you mentioned, these shockwave balloons, they get pretty stuck in there because once they are used, they rewrap not so tightly, and you're already in really calcified disease. So it can be a bit of a thing.
Yeah, I love that. I think you deliver through a guide extension and then pull back. I think that's the way to go.
And then, so we're going to stent this. I think I stented this I'm pretty sure this is a big boy Megatron stent. I mean, I think we got a very good result. We were able to get great flow to that obtuse marginal system. We'll see how he does. But I mean, you can appreciate how sort of underexpanded this previous stent was and how much bigger you can really make this vessel. I mean, and I'll show you the IVUS now, but it's a lot bigger than I think was appreciated without imaging. And I'll show you the nodule here.
So you stented through most of that was through a prior stent.
Yeah, and we expanded that prior stent before we, did the. It's trying to load my IVUS here. But we expanded that stent before we decided to put our other stent in. So I'm going to pause this so I can change the back to default here. And you can see there's just some nodular calcium, and then here's a stent that's just a little small for the vessel, right? I mean, it's really not the size of the vessel. And there's some more eccentric calcium. You can see how much bigger the vessel likely is than that stent. I'll go a couple frames back, but that stent is not the right size for this vessel. And then
so how would you size here, Chris? I mean, you can see really the adventitia there.
Yeah. So what I do is I find wherever I can see the 270-degree arc, for example. So here I can see most of everything. So you can be media to media here, and you can be media to calcium, or you could perhaps suggest that the media is somewhere in here, although I don't really recommend people do that. And essentially what I'm looking to do is come one size off of media to media as sort of the goal, because that's what was in most of the trials, is one size off of either EEL to EEL or media to media. You can also take the luminal size and use that as a one-to-one, but I don't like that, especially with these huge nodules, because you just never really find the best normal part. And so I sized this to media, and then came just down a tiny bit on size. And I frequently actually use shockwaves at the media to media side, because you're at such low atmospheres, and I really want to maintain apposition. And I don't want to be floating in any portion. So if a vessel like this, it has a branch that went to the bypassed portion of the lower circ, if I'm going to have to shockwave across that branch and then back, I need a shockwave balloon that touches the walls all the way back to the left main. And so I'm going to need a shockwave balloon that's probably a little bigger than what goes in the more distal obtuse marginal segment. And so I'll just oversize that a tiny bit. So maybe I would have used a 3.0 if I only fix that. I'll use a 3.5. And because it's only a 4 atmospheres, there's no real problem there.
Yeah. So right here, let's say the media to media looks about 3.0 there. So you would, what size shockwave balloon?
I would take a 3 here. I mean, this is I would take a 3.
And then stent size, what do you stent?
I would take a 3. In this case, this is probably a little more than 3.0, so I would probably take a 3.0 stent. You could take a 2.5 stent and deploy to high pressure if you're trying to save a step and not post dilate. I find that doesn't work as well as I used to think it does, and I've sort of reverted back to using the appropriate size stent to nominal pressure, and then just having a 1-to-1 sized NC that I can go to high pressure, 18 or 20 atmospheres if I want to post dilate. I think that probably works a little better than using the stent balloon of a slightly smaller stent to deploy it to 18 or so. I used to think that saved time, but after doing, a couple hundred cases and imaging after doing that, I realized that we just get a better result if I just deploy the stent and post dilate with an NC, and then IVUS after that or image after that. It just ends up being a better result in the end.
Awesome.
That's great, dude. I think the recurring theme with all of these cases is that imaging and physiology is critical, and if you're not doing it, you're doing your patients a disservice, especially if you're going to be modifying calcium. So that's super helpful.
Completely agree. And I think that I have not been more tricked by angiography than this year. I mean, there have just been so many cases where we did angiography, then we did physiology and it was positive, and then we went and IVUS'd and there's a napkin ring or there's a nodule or there's a whatever. It's sort of critical. And you can see how much bigger this is now, right?
Yeah.
I mean, this is a much bigger stent than what was there before, and we have good coverage to the ostium where that left main takes off. So we're happy with it.
Yeah, in addition to just doing what's right for the patient, it's your referrings are going to send you a lot more cases. If you're not sending them patients back that still have angina and you tell them the angiogram's fine, and then they can go years before they even notice that, oh, we missed that crap, so I think it's good for everybody. So.
Yeah.
Awesome.
All right.
Thanks. Appreciate it.
Thanks, man.
Thanks, guys.